This is my client, Donna, and this is part 2. And she is tight in the heel cords. Dorsiflexion is 90 degrees. And I'm suspecting that there's rigidity in the talus, in the ankle joint. But there most certainly is rigidity in the subtalar joint. I'm trying to rotate the foot, and that is literally all I can get. Very, very little motion. I'm trying to evert the ankle, very little motion. I'm trying to invert, very little motion. This is just a very, very rigid subtalar joint, and that's on both sides. Now, there's lots of freeway space under the left knee. I've got 2 fingers of space there, and it's very hard to take up the slack. I can't get any spring mobility. The right knee has a flexion contracture that's a little bit more than the left, and I'm at 3 fingers of space underneath that knee, and again, just very, very rigid. Now, you might think that she has tight hamstrings, but no, she's got excellent range in her hip. Minimal tightness, a little bit of a hard end feel in internal rotation of the hip, and that's the same on both sides. So we will treat that. The pelvis is extremely rigid. I'm trying to do side glide. And maybe if I put 100 pounds of force, maybe I'd get some movement happening up in the upper lumbar and thoracic spine, but the pelvis itself is extremely rigid, and I cannot take up the slack through this structure, as you'll see in other videos. Let's have you lie on your stomach, please. And you want to bring the camera view a lot closer. Looks like you're going to walk out the door with some of our dog hair off the sofa. We try and clean it, but what can I say? I should tell everyone to bring a pair of pants that's designs, you know, so you can hide that. All right, so her sacrum is more posterior. Can you scoot down a little bit? And can you see? No, Karen. Just scoot way down. No, bend down. That's what I want. I want to show that the sacrum is higher than this thumb is on her left PSIS, and this thumb is on her sacrum, and it's much higher. Her sacrum is posterior in relationship to her ilia, and it's wedged, and that's why there's no spring mobility throughout the pelvis. That's why it's rigid, and it's pulling on sacrotuberous ligament, which feels like bone. This is ligament. There's no bone right here, but it feels like bone because it's very rigid. And no matter what direction I try and create motion, this is like a block of granite. And that will also wedge L5. And so L5 does not have any mobility, but it'll put extra stress and extra movement on L4 at the L4, L5 joint. And she has good mobility throughout the rest of her spine. Let's have you lie on your back now. She's able to reduce the numbness in her arms and hands by straightening out her shoulders, bringing them back a little bit, and that's very encouraging to me. She's extremely rigid at the AC joints. I'm trying to spring that way, a 45-degree oblique, and I can't take up the slack. I can't get any spring mobility. And the same thing when I push towards her feet. On each side, I'm on the shelf of her scapula, which are very high. Her scapula are very high up. There's just no spring there. Very rigid scapular and AC joint. Interestingly, she probably has almost full shoulder range of motion, but this is glenohumeral joint, a little tight there, not quite 180, more like 170, but coming up sideways. Nope, we got full range there, except that she's a little anterior, so she doesn't quite flex all the way. If we test internal and external rotation, you can see the compensation there. See, if I block, then true internal rotation is 45, and external rotation is pretty generous. So I think that internal rotation will actually increase. Right now she compensates. Now we're getting scapular mobility. So I think that might increase when we free up your scapula. So everything I've shown in the camera is something that we should be able to treat the big concern being the knees. You know, can I gain motion in that knees given how long they have been that way? So that's the one caveat. Your head is a little hyperextended. Your chin is a little higher than your forehead. When I try and side bend under your mastoid, there's no give. And same thing on this side. And when I try and shear C1 to the left, you can see there's a little bit of play. And when I try and shear the transverse process of C1 over to the right, there's a little bit of play. When I come under C1, there's a little bit of rotation. In fact, there's generous rotation. And then same thing at C2. But when we come in front of the mastoid, and I try and spring downward on the left, which would be left rotation, it's just very, very rigid. So you're really locked up at the upper joint. And these are things that are treatable.
Yay.
And we will treat it today, and then we will film your response to treatment. And the best thing is we then teach you how to keep that mobility, that gain in mobility. So I have a huge amount of optimism based on my experience in treating people with these presentations. I really think that I can help you.
Yay!
And I can help everything that I mentioned. Again, a little concern on the knees, but we will sure give it our best try. And then we'll refilm your response to treatment.
Okay.
Any thoughts?
No, I'm super excited.
Very good, thank you.